So today is the emergency medicine top decile quiz led by myself. For those of you who have not met me before, my name is Shoaib. I'm one of the co-founders of Bite Medicine. And as always, it's an absolute pleasure and a delight to be joined by so many of you on a Friday afternoon when I'm sure you could be doing millions of other things. So thank you so much for joining us. We have guests from all across the globe. Very grateful. Just before we get started, a few housekeeping announcements. As always, we run our certificate scheme. If you've attended one webinar and fill out the feedback form at the end, you're eligible for a certificate of attendance. Please do bear with us because the certificates come from Medigate and we have been a bit slow to get them out. So if you haven't received your certificate, just hold on, you should receive it in the next sort of week or two. Okie dokie, so without further ado, let's get into things. So for those of you who have not attended one of our top decile quizzes before, we've been running these since April. And actually, I think it's the best way to recap a topic and actually learn about a topic. Getting questions, doing as many questions as you can, getting them wrong, that is the best way to learn. Don't worry if you find these questions hard. They have purposely been designed to challenge you. And what I'd say is, we've all been on a ward round where we're grilled by a consultant or we get things wrong. And actually that's the best way to learn because you never forget those experiences. So if you get things wrong, don't worry, ask questions, we're always here to help. The idea of today and tomorrow's collaboration with Smile, where we will be holding another or a second part of the quiz, which will go on to different topics. We look to basically cover most of emergency medicine over today and tomorrow. Today we'll be covering a few of these topics listed here, and the format will be 4 cases with multi-step SBAs, which hopefully you guys are getting used to, followed by a few rapid fire questions at the end. And there will be a total of 12 or so questions. The slides have not been uploaded because obviously if I uploaded the slides, you'd know the answers to all the questions. But I will upload all of the questions and all of the answers at the end of the session, along with the recording. So that will all be going onto our website here at bitemedicine.com/watch. Okay, and we'll be using Menti for the questions. So please do log on to Menti, and I'd advise using your phones for Menti, because that way you can actually look at the PowerPoint slides as well as having the question on your phone rather than having to switch between tabs. So try and get onto Menti on your phones, but if you can't, of course, that's not a problem. You can do it on your computer. All right, let's get straight into it. So first case of the day, you are a clinician working in the emergency department. So you're working in A&E. And you receive a phone call from an ambulance saying that a patient is having a tonic-clonic seizure. It's been 6 minutes and the patient has been given rectal diazepam. They are continuing to seize. So 6 minutes, patient's having a tonic-clonic seizure and they've been giving rectal diazepam. Are you guys worried or not worried? Yeah, I'd be kind of worried, like they're having a seizure. I mean, it's only been 6 minutes, no big deal. Their observations are pretty okay. Heart rate's a little fast. Blood pressure's a tiny bit low. I mean, I wouldn't be, panicking at this point, but yeah, it is a bit worrying, isn't it? So first question, let's go over to Menti. So if you all go over to menti.com, hopefully we can get this working. You'll be able to answer them on Menti. And if you type in the code 692740, hopefully that should work. Okay, so if you all go on to Menti, I'm just going to wait for a few more of you to log on because I know it can take a bit of time. Go to menti.com, put in the code 692740, and we will start the quiz once you are all ready to go. Give it a few more seconds. Yeah, please don't answer on the chat because it just ruins learning experience. So please do answer on menti.com. Okay, I think that's enough. Sorry, it's just taking a bit of a while. My computer's going a bit slow today. All right, the faster you answer, the more points you get. So you have to answer correctly and quickly. The patient's had a tonic-clonic seizure. They're still seizing. What is your next step? So we have about 40 seconds to answer that. We have a bunch of IV medications, IV phenytoin, IV lorazepam, IV phenobarbital, oral midazolam, or rapid sequence induction. So it's been 6 minutes, they're having a tonic-clonic seizure, and they're still seizing. They've come into A&E and you're looking after them. What are you going to do next? That is the question. Let's see what you guys think. IV lorazepam, okay. Good, so that is the correct answer. Let's go and have a look at the answers on the PowerPoint. So there was actually a question before which got missed, I think, for some reason. I think that was just a computer error on my part. But the first question was supposed to be, how long does a tonic-clonic seizure need to last before causing neuronal damage? I mean, you guys won't be able to answer this now, but that's fine. The answer was 30 minutes. So if a tonic-clonic seizure lasts for 30 minutes, you start to get irreversible brain damage. Obviously, that's an average and it varies between people. But as an average, if your seizure lasts 30 minutes, you start to get irreversible brain damage. And does anyone know which region in the brain is most sensitive to this damage? Yeah, so some people were saying temporal, like specifically. So the hippocampus, so someone's got it there. The hippocampus is usually the most sensitive area in the brain to toxic damage, whether that be tonic-clonic seizures, whether that be carbon monoxide poisoning or toxins. It tends to be that the hippocampus is usually one of the first areas to get affected. And it's the same in seizures. So if you have a tonic-clonic seizure lasting 30 minutes, you're at risk of brain damage, essentially. So sadly, that question got missed, but it doesn't matter. We've still got 11 other questions. So what is your next step? Most of you went for IV lorazepam, so a nice, easy question to get started. But the question is, the patients already had a rectal diazepam, so why are you giving them further benzodiazepines? What is the rule? So the answers are all listed here. The point is the patient can have 2 doses of benzodiazepines before you move on to something else. So if they've had rectal diazepam, you can give them another dose of a benzo, whether that be another dose of rectal diazepam or IV lorazepam. You can have 2 doses of benzos before you escalate to a different treatment. Some of you went for IV phenytoin. That's incorrect. As we said, you'd give the lorazepam first. If that fails, you would then move on to phenytoin or phenobarbital. You never give oral medications in a seizure because they can't swallow. There's no point of giving anything orally. You can give something called buccal midazolam, which is a bit different. It's a fluid you squirt under the tongue and it gets absorbed that way, but it's not swallowed. So oral and buccal are 2 different things. And then rapid sequence induction is where you intubate the patient. That's kind of end stage if you've given medications and they're still not settling. Okie dokie. So a brief bit about status epilepticus. So I want to do some questions and then go on to the actual theory because that's the best way to learn, really. So status epilepticus is defined as a seizure which lasts more than 5 minutes or recurrent seizures without gaining consciousness in between the seizures. And you can have 2 types, convulsive or non-convulsive. we've done a lecture on this, so I don't want to go into too much detail. But the point is, we're worried if it's convulsive status epilepticus. And what we mean by convulsive is a tonic-clonic seizure. So if they're having tonic-clonic status epilepticus, i.e. a tonic-clonic seizure lasting greater than 5 minutes, or multiple tonic-clonic seizures without regaining consciousness in between, then we are worried. What about non-convulsive status? Are we worried about non-convulsive status epilepticus? Got a few no's. Yeah, not as much really. So there's lots of different types of non-convulsive status epilepticus. One of them would be, for example, an absence seizure, which is not resolving. The reason we're less worried is because the risk of neuronal damage is a lot lower with non-convulsive status epilepticus. So if you're having a tonic-clonic seizure, because you're having so much brain excitation, the risk of brain damage is high. In, for example, a non-convulsive absence seizure, which lasts longer than 5 minutes, the level of brain activity is not the same. The risk of death to the neurons is a lot lower. So the point is, status epilepticus is a prolonged seizure, and it can be split up into convulsive and non-convulsive. Convulsive is what we worry about, and that typically refers to a tonic-clonic seizure. The pathophysiology is quite straightforward. You have excitatory neurotransmitters and inhibitory neurotransmitters in the brain. For some reason, that balance is skewed, and you get too much excitation, you get a seizure, and that seizure does not terminate. As we said, cerebral damage occurs within approximately 30 minutes of convulsive status epilepticus, and that's actually stated in the International League of Epilepsy guidelines. Mortality is high, and status epilepticus is the most common neurological emergency in children, okay? So it's the most common neurological emergency in children. It's very common to have young children coming in with fits into the emergency department. And as you can see, the mortality in adults is up to 20%, and the mortality in children is up to 15%. So that's high. 1 in every 5 or 6 patients will die. What is the most common cause in children of status epilepticus? A bit of a recap on what we did before. Yeah, infection or febrile, temperature. So it doesn't matter what the cause of that temperature is, but a high temperature in children can cause seizures. So here are the causes listed here. The most common cause in adults is epilepsy. So patients with diagnosed epilepsy, but they aren't taking their medication properly. They then go on to have seizures, and those seizures can be prolonged and end up being status epilepticus. Febrile convulsion is the most common in children, and most commonly due to viral infections. The most common cause of a febrile convulsion leading to status epilepticus is a viral infection. And then you have a bunch of other causes which are less common. So other infections, brain bleeds, alcohol, recreational drugs, electrolyte imbalances. But when someone comes in with status epilepticus, you're thinking these two things at the top of your mind, depending on what age group the patient's in. And this is the bit that the question touched on. So what is the management? So very quickly, we'll go into it. Early on, particularly if they're in the community and it's hard to get intravenous access, you can't get a cannula in, you can give diazepam into the rectum. So you just put a little tube into the rectum and it administers the diazepam. Or you can give buccal midazolam, which is an oral solution, which isn't swallowed, but just goes under the tongue. Once you've got intravenous access, the first line is IV lorazepam. And you can give, remember, you can give 2 doses of benzos before you move on to the next stage. So you can give a dose of rectal diazepam and IV lorazepam. You can give 2 doses of rectal diazepam if you wanted. But the point is you can give 2 doses of benzos before escalating to phenytoin or phenobarbital. So these are the NICE guidelines. You can look these up, but the point is you start off with benzos, you then usually move on to phenytoin, and at this point, at the 10-minute mark, you want to start to let an anaesthetist know because your patient may need intubation. And finally, if the phenytoin doesn't work, then you need to anesthetize the patient. You need to knock them out to stop the seizure. And obviously, the longer the seizure lasts, the poorer the prognosis, the more risk of brain damage. Okay. So in a nutshell, just think of it, early on, give benzos, later on, give phenytoin, and then finally, you want to anesthetize the patient if they're not responding. Okay, so that's status epilepticus in a nutshell. I'm sorry I'm going quite fast, but we've got a lot to cover. I'm just having a few look at the questions. So you wouldn't do this as you would administer the medication as a foundation doctor, but once you're getting to, the initial steps not working, you'd want to escalate to a senior. And the management in kids is very similar. So this is for adults, but the management in kids is pretty much identical. You start off with benzodiazepines, and then you move up to phenytoin, and then you anesthetize the patient. The only difference is the time frames are slightly different in children. I will stick around at the end for a Q&A. So any questions you have, keep them in the back of your mind. I'll definitely get to them at the end. But for now, let's move on to the next case. So we have an 18-year-old medical student. So this, we've all been medical students at one point. We've all been 18. Presents to the GP feeling generally unwell. He's wearing sunglasses and complains of a stiff neck with a pounding headache, and he's vomited twice. On examination, he is Koenig's sign positive, and there is no rash. So are we worried about this patient or not worried? So a lot of people are worried. Yeah, I guess. I guess so, yeah. I mean, obviously, I won't say what the underlying diagnosis is. The underlying diagnosis is kind of worrying, but from an observations point of view, he's doing quite well. So the point is, you've got this gentleman in GP who's presented like this. Let's go on to the next question. Yeah, I can see somebody saying he's got a high temperature, but I mean, it's just he's got some sort of infective cause, doesn't he? What is your first line management for this patient in the community? So you have someone presenting with photophobia, young chap, headache, etc. He's not got a rash. His observations were, you guys saw, they were okay-ish. What are you going to do? So we've got various antibiotics through different routes, or none of the above. So you're going to do nothing, or you're going to do something at this point. Be interested to see your responses. Okay. Very interesting. So I put this in here to catch you out. You would do none of the above. There might be a bit of additional information that you need to know, but I will go into it. The point is, a lot of you have gone for IM benzyl penicillin. So when do you give IM benzyl penicillin in the community? Because that seems to be the most popular answer. So there's two instances you'd give IM benzyl penicillin. If you're worried about sepsis, i.e. do they have a rash? Are they really, really unwell? Or the other instances, can you not get them to hospital in time? There's nothing in the case which suggests that you can't get the patient to hospital in time. You can just, most places, especially in the UK, you just call an ambulance and they get to hospital quite quickly. And there was no evidence of sepsis or a rash. So if we go back to the case, he's slightly tachycardic, his blood pressure is ever so slightly low, but he's a young chap anyway. His rest rate is pretty much okay, and his oxygen's fine. He's got a temperature, that's no big deal. We know he's got meningitis, so he will have a temperature. There's no indication of a rash, so we're not worried about meningococcal sepsis. Therefore, we do not need to give IM benzyl penicillin. Okay, so going into these, the point is, you do not need to give any antibiotics. You get the patient to hospital. You only give antibiotics in GP if you're worried about meningococcal sepsis, i.e., do they have a rash? Are they really tachycardic? Are they really hypotensive? Are they confused? These will all be worrying features. Otherwise, our guy was kind of well with his meningitis. So you don't need to do anything. You just send them straight to hospital from GP. We are going to go into the management in a second. So that's all coming. The next question. So the quicker you answer, as usual, the more points you get. So we've got the patient to hospital now. He's had a lumbar puncture. Which of the following is most suggestive of pneumococcal meningitis? So for those of you who don't know what pneumococcus is, that's Streptococcus pneumoniae. Which of the following is most suggestive of pneumococcal meningitis? Alpha hemolysis, beta hemolysis, gamma hemolysis, gram-negative cocci in chains, or gram-positive cocci in clusters? Someone has said dirty question. It is a dirty question. I've made these questions pretty difficult, so don't worry if you find them tricky. Okay. Well, I mean, a fair few of you got it right, to be fair, so well done. You know, 46, that's good. That's good. It was a tricky question. So the answer is, well, firstly, what is pneumococcal meningitis? It's Streptococcus pneumoniae. Streptococcus pneumoniae is a gram-positive coccus, okay, which causes alpha hemolysis on blood agar. So these are all the options listed. If we go into each one, first of all, exam technique, always exclude what's wrong. As I said, strep is gram-positive coccus, so we know gram-negative coccus must be wrong. Gram-positive coccus in clusters is referring to staphylococcus. Streptococcus forms gram-positive cocci in chains. Okay, strep forms chains, staph forms clusters. So you can exclude the bottom two, and now it's just knowing what the hemolysis pattern is on blood agar, and sadly that's just something you have to learn. And it's something that we all learned once upon a time in one of our microbiology lessons, probably in like the first year of university, and then forgot completely about it. But it does pop its head up every now and again. So strep pneumoniae causes alpha hemolysis. And we'll go into all of what this hemolysis stuff is in a second. Meningitis, what is it? It's inflammation of the meninges. The meninges line the brain. Most commonly, it's due to inflammation of the arachnoid and the pia, so the inner layers of the meninges. And it's due to an infective cause, so bacterial, viral, or fungal, and rarely you can have non-infective causes. I don't really want to go into those. The most common bacterial causes are strep pneumoniae, also known as pneumococcus, and Neisseria meningitidis, also known as meningococcus. Which is the most common in the UK? Strep or Neisseria? So everyone's gone for strep. Well, okay, one person, Amelia's gone for Neisseria. The answer actually in the UK is Neisseria is the most common. In other parts of the world, particularly in the US and other Western countries, strep seems to be the most common. But in the UK, Neisseria meningitidis, according to NICE, is the most common cause. Enteroviruses are the most common viral cause, and actually viruses are the most common cause of meningitis. Bacterial causes are rarer. So enterovirus is the most common cause overall, but viral meningitis rarely kills. Bacterial meningitis has a high mortality. So as we can see here, bacterial meningitis is 25% mortality in adults, viral meningitis less than 1%. So it's fairly rare, but it kills, okay? So that's the point. And this is what the question was asking about. So how do we classify Streptococcus? And I went into this in quite a lot of detail on my meningitis lecture, so please do feel free to check out the recording. Streptococcus, the first way to classify it is as a gram-positive coccus. The second way to classify it is based on its hemolysis pattern on blood agar. And you can split this up into alpha hemolysis, beta hemolysis, or gamma hemolysis. So I put beta hemolysis first here because that refers to complete hemolysis. Alpha hemolysis refers to partial hemolysis, and gamma refers to no hemolysis. Basically what this means is it just looks a particular way. When you grow the bacteria on agar, you have these patterns of hemolysis around the colonies of bacteria. And you just need to learn this table, sadly. So beta hemolytic streps are your group A and group B streps. Alpha hemolytic streps comprise strep pneumoniae and strep viridans. These do not fall into a particular group. They have their own name. And then finally, gamma hemolytic is group D Streptococcus. So this is just the way you classify Streptococcus. It's something that you more probably need to know for your preclinical exams, but it's worth remembering up till finals, I would say. I never got asked about this, but microbiology is a very hot topic, so they may well ask you something like this. Beta hemolysis appears like this image here, and alpha hemolysis appears like this image here. So really just learn that table, sadly. And you might be thinking, well, there's group A, group B, and group D. Where's group C? There's actually tons of groups. I think it goes up to group U, but the only relevant bacteria in humans are A, B, and D. C, E, F, G, etc. do not cause problems in humans. So only group A, B, and D are relevant in humans. That's why those are the only ones listed here. This is the main point. How do we manage a patient with meningitis or bacterial meningitis specifically? So if they're in primary care, you can give benzyl penicillin if there's evidence of a non-blanching rash or you can't get them to hospital quickly. As I said, in the UK, for most GPs, you can get a patient to hospital fairly quickly just by calling 999. A non-blanching rash is associated with meningococcal meningitis, so Neisseria meningitidis, but it can also occur in any other bacterial form of meningitis. Why do we only give the antibacterial in primary care if there is a non-blanching rash? What is the, we always worry about a non-blanching rash in medicine, whether that be children, whether that be adults. What is the concern about a non-blanching rash? Yeah, so you've all got it, sepsis, okay? Sepsis or DIC, disseminated intravascular coagulation. But at this very basic level, if a patient has a non-blanching rash with evidence of infection, that suggests they are septic. Therefore, you need to give antibiotics ASAP. So non-blanching rash suggests sepsis, therefore give antibiotics immediately within GP. Once you get them into hospital, you then give IV, usually cephalosporin. So that's either cefotaxime or ceftriaxone. And depending on the age of the patient, you can also give them amoxicillin. So the ceftriaxone will cover the Neisseria meningitidis, and it will also cover strep pneumoniae. You add in amoxicillin if you're worried that the patient has listeria meningitis. So amoxicillin will cover listeria. Go and have a look at my meningitis lecture, and we go into this in a lot more detail. The point is, you give a cephalosporin plus or minus an amoxicillin. You also give steroids, and they should usually, well, according to NICE guidance, you can give them before the antibiotics actually. And the point is they reduce the inflammatory response and actually improve mortality. But ideally they should be given before or at the same time as antibiotics, and should be given within 12 hours at the latest. Finally, if you're unsure if it's a bacterial or a viral meningitis, you would give them both antibiotics and acyclovir. What usually happens is, for a patient presenting to A&E, if they have evidence of meningitis, you just give them the antibiotics and acyclovir to cover your bases. You'll then do a lumbar puncture and find out what the actual organism is, and then you can treat accordingly. Okay, there's a lot of questions going on there. I will come back to them at the end of the chat. There's just one there. Shouldn't we start with empirical therapy? This is empirical therapy. So cephalosporin is empirical, i.e. what that means is, empirical means before you know what organism you're treating, you give a cephalosporin. We will come back to more of that at the end. Please do hold your questions to the end and I'll definitely get to them. All right, oh, sorry, let me just go back to the case. So you have a gentleman, a 50-year-old gentleman who presents to the emergency department with coffee ground vomiting and abdominal pain. He's jaundiced and has evidence of shifting dullness. Looking at those observations and the history, again, are you worried or not worried? This is always the most important question that you need to ask yourself in emergency medicine. Because that's going to determine how quickly you act and whether you're going to escalate this to your consultant or not. So I would certainly be worried. Anyone who's coming in actively bleeding, this guy's actively bleeding, right? He's vomiting out coffee ground vomit. He's slightly tachycardic. His blood pressure is all right, actually. But the fact that he's actively bleeding is extremely concerning. As you can see here, he's vomiting out some coffee ground vomit. Let's go over to the question. As always, the quicker you answer, the more points you get. So he's rushed off to endoscopy and he's noted to have gastric varices. What is your first line management? So assume we've done all the A, B, C, D stuff and he's now been taken to endoscopy. What is the definitive management going to be here? Band ligation, sclerotherapy, IV pantoprazole, clipping, or none of the above? So he's now in endoscopy and we're looking to definitively treat his gastric varices. Okay. Interesting split there. So a lot of you went for band ligation. When do we use band ligation? Very good. So smiley face said esophageal. Ryan, Natasha, you're all absolutely right. Band ligation you use for esophageal varices. Sclerotherapy you're using gastric varices. What's the difference between gastric and esophageal varices? Gastric is in the stomach, esophageal is in the esophagus. Okay, let's go and have a look at the answers. So firstly, going back to the case, I mean, you don't actually need to know much on the case at all to answer this question because the question itself told you that he has gastric varices. The point is here is that he has an upper GI bleed and it's a variceal bleed because he's got evidence of liver disease, okay? If he has evidence of liver disease, it's almost certainly gonna be a variceal bleed. He's jaundiced, he's got ascites. So this guy's got decompensated liver disease and he's got a variceal bleed. And he's kind of tachycardic. The question told us that he's got gastric varices. So you don't even need to know the case history actually to answer this question. You just need to know how to manage gastric varices. Band ligation is first line for esophageal varices. Sclerotherapy is first line for gastric varices. PPIs, you do not use them in a variceal bleed. You use them for peptic ulcer disease, patients who are bleeding due to a peptic ulcer. Clipping is used for non-variceal bleeds, i.e. peptic ulcer, usually. Obviously, none of the above is not right because sclerotherapy is the correct answer. We will go into all of these bits and pieces in just a second. I just want to get through, we've got 3 questions on this case. So let me get through the questions, and then we're going to go into upper GI bleeding in more detail. Question 2. So remember, we have this gentleman who's got a variceal bleed. What grade of hemorrhagic shock is the patient in? So this is actually, you need to know this for your final exams. You need to know the grades of hemorrhagic shock. So it's important that you know. There will be a table, and again, this will all be explained. But this is something you certainly need to know. And we had a lecture on shock, which went into things in quite a lot of detail, but I'll briefly go over the summary in a few slides. If you guys wouldn't mind answering in the on the Menti, if you're unable to answer on the Menti, just hold your answers and keep them to yourself if you wouldn't mind. Yeah, okay. Grade 1, grade 2, grade 3, grade 4, grade 5. So hemorrhagic shock is graded from 1 to 4. 5 does not exist, so that's automatically wrong. So we have grades 1 to 4. I'll go into what these grades are in a few slides, but just from an exam technique point of view, let's pretend that we don't know what hemorrhagic shock is, and we don't know how to classify the different grades. This is where exam technique comes into play. So if we go back to the case, I remember I asked you, are you worried or not worried? We all said we're worried, but if we look at the observations, he's not actually doing that bad. He's tachycardic, his blood pressure is okay, he's breathing slightly fast. So logic would tell us, therefore, it's not going to be grade 4 or grade 5 shock because those seem quite extreme. That leaves us with grade 1, 2, or 3. Now, grade 1 is very minor, so it's probably not going to be grade 1, which leaves you with grade 2 or 3. And you could have guessed, therefore, that it'd be grade 2. You know, this is just if you don't know what, you don't have a clue what hemorrhagic shock is, and you don't know what you're doing, you haven't learned this topic yet, then exam technique would allow you to try and, you know, narrow down the answer to at least grade 2 or grade 3 shock. There are very specific criteria for all of these, and we will go on to them in a few slides. The point is this patient is in grade 2 shock. But as I said, we'll come on to what shock is in a few slides. Yeah, don't worry if you're finding these questions hard. I purposely made them difficult. So let's see where we're at the moment. We have Love Sight in first place with 3,706 points. So this is the halfway mark of the quiz. There's still a lot to play for, so don't worry if you're lagging behind a bit. Next question. I think this is probably my most favorite question of the quiz. Which of the following is least related to upper GI bleeding? Angiodysplasia, hereditary hemorrhagic telangiectasia. You might be thinking, what on earth is that? Burns, raised intracranial pressure, or paracetamol? Yeah, so I can see some of you saying these questions are difficult. Sorry about that. They are difficult, so don't worry if you're getting them wrong. As I said, the best way to learn is by getting these things wrong, and then you're never going to forget them when it comes to your finals. Okay, good. I was hoping that would be a bit harder, but I guess you guys are smart. So paracetamol very rarely causes upper GI bleeding. All of the other ones do cause upper GI bleeding. And you might be thinking, how on earth do some of those cause GI bleeding? Well, if we take it from the top, I know a lot of you are asking, how do these different things cause GI bleed? It's all written down here on this slide, and I'm about to go through it. So angiodysplasia is a malformation of the capillaries within the gastrointestinal tract. Basically, you've got malformed capillaries which are prone to bleeding. It most typically causes a lower GI bleed, but it can cause an upper GI bleed. Hereditary hemorrhagic telangiectasia, long name. It's a hereditary condition, as the name suggests, and it causes thin-walled blood vessels. How does this normally present? What's the most typical presentation of bleeding in someone with HHT? So yeah, epistaxis. 90% of patients with HHT have epistaxis. They will also have these little dots or freckles on their lips, which is a classic sign. So yeah, really rare condition, but you need to know it for your finals. It can cause bleeding, particularly epistaxis, but it can cause GI bleeding because of these thin-walled blood vessels. Burns cause curling ulcer, and raised intracranial pressure causes Cushing's ulcer. So how does burns cause a curling ulcer? Well, if you have burns, you lose lots of fluid. Remember, the skin is a barrier. You can think of the skin as keeping the fluid within the body. If you have burns, you lose that protective layer, you lose fluid, you become hypovolemic, and that causes a reduced perfusion of the stomach lining because of the hypovolemia. And that can lead to an ulcer of the stomach and therefore an upper GI bleed, and that's known as Curling's ulcer. So that is an association between burn victims and ulceration of the stomach. So that's a really high yield and important association that you need to know. And that's typically with significant burns. How does raised intracranial pressure cause a upper GI bleed? Again, this is a high yield association that you need to know for your exams. As you start to get compression of the brainstem with raised intracranial pressure, the vagal nerve becomes stimulated, and that leads to increased acid production in the stomach. Vagal stimulation leads to direct increase in acid production in the stomach, causing a ulcer, and that's known as a Cushing ulcer. So there's a direct association between raised intracranial pressure and upper GI bleed. Paracetamol is generally considered safe. It's very rare that paracetamol can lead to an upper GI bleed, rarely, if patients overdose on paracetamol and then go into decompensated liver disease and then go into variceal hemorrhage. But that's very rare for that to happen. The question says least related. Paracetamol very, very rarely causes GI bleeding. And it's safe to use. It doesn't irritate the stomach in the same way that aspirin and ibuprofen do. Okay, the point is, paracetamol can very rarely cause upper GI bleeding, but as I said, on the whole, it's considered safe, whereas all of these are associated with upper GI bleed. Okay, so briefly, upper GI bleeding, these are your common causes. If someone comes in vomiting coffee ground vomit, that is suggestive of an upper GI bleed. And right at the top of your mind, you should be thinking, is this peptic ulcer disease? Is this a variceal bleed? Is the patient, for example, an alcoholic, or do they have chronic liver problems? Is this esophagitis? So does the patient have chronic acid reflux problems, which is irritating the esophageal lining and causing a bleed? Or is this a Mallory-Weiss tear? So Mallory-Weiss tear is a very small, shallow laceration at the bottom of the esophagus typically, and it's caused by retching. So patients who are retching, and it's usually seen in alcoholics. And these are all of your uncommon causes. So our patient had a gastric variceal bleed. It's rare. but it can happen. The point is, I would remember particularly the top two, peptic ulcer disease and esophageal varices, as the commonest causes of upper GI bleeding. And this is a brilliant diagram which summarizes everything you need to know for management of an upper GI bleed. And it's all on this flow chart. And I will be releasing these slides at the end of the lecture, so you can go and have a look at this. The point is, always resuscitate the patient. So give them IV fluids, give them blood if they need, A, B, C, D, E, as with any emergency. You rush them to endoscopy, and then you figure out, are they having a non-variceal bleed or a variceal bleed? So on endoscopy, you'll be able to tell which type of bleeding they are having. If they are having a variceal bleed, and it's a gastric variceal bleed, the first line is sclerotherapy. So that's this thing here, N-butyl, I can't really pronounce the rest of it, but it's this thing here. And you inject that into the actual variceal bleed, and that basically clots off the bleed. So it's known as a sclerosing agent in that it stops the bleeding when you inject it into the bleeding site. So that's the first line for a gastric variceal bleed. The first line for esophageal variceal bleed is band ligation. So that's literally where you get a little band and you tie it around the variceal bleeding point to stop the bleeding. And those are your two options for variceal bleeding. You need to know that for your finals exams. If it's a non-variceal bleed, for example, due to peptic ulcer disease, then there are various options all listed here. So it can either be mechanical, so that would be a clip, for example, thermal coagulation, or you can use fibrin or thrombin. And you give a PPI after endoscopy. So I can see a few of you asking about terlipressin and prophylactic antibiotics. You give the terlipressin before endoscopy. Why do we give terlipressin? What's the point of giving terlipressin in a variceal bleed? So it reduces the portal pressure. It reduces the portal blood pressure, and therefore will reduce the pressure within the variceal vein. If you have lower pressure within that vein itself, you're going to reduce the amount of bleeding. So terlipressin reduces portal pressure. And very quickly, just going into shock, we have the 4 types of shock: so distributive, cardiogenic, hypovolemic, and obstructive. I've gone into this in a lot of detail in my shock lecture, but the definition is circulatory failure resulting in reduced oxygen delivery to the tissues. Hemorrhagic shock comes under hypovolemic shock. So hypovolemic shock can be classified into hemorrhagic and non-hemorrhagic. This is what I really wanted to point out here, is the classification of hemorrhagic shock. So you need to know this for your exams. Hemorrhagic shock can be classified into grade 1 to grade 4. The way I would remember this, obviously don't learn all of the figures because this is going to be impossible to learn. Grade 1 is where the patient is pretty much okay. Their heart rate's fine, their respiratory rate is fine, their blood pressure is fine. Grade 4 is when the patient is super unwell. Their blood pressure will almost be unrecordable. Their heart rate will be above 140, and they will be confused and unresponsive. So learn grade 1 as being basically a normalish patient, and grade 4 as a super unwell patient. And then you've got grade 2 and grade 3 in between. So how do we differentiate between grade 2 and grade 3? Well, in grade 3, the patient is hypotensive, whereas in grade 2, the patient's blood pressure is normal. So 1 is a normalish patient, 4 is a very, very unwell patient. In grade 2, the patient's blood pressure is normal, and in grade 3, the patient's blood pressure is low. So that's the way you can differentiate between grades 1 to 4. This is only used for hemorrhagic shock, so only for bleeding patients. We do not use it for any other type of shock. So you can only use this grading system for patients who are bleeding. Yeah, I wouldn't worry too much about getting into the nitty-gritty. Just remember those points that I mentioned. Okay, this is the final case. Hopefully we'll be done in the next 10 minutes, and then I'll take questions at the end. So we have a 22-year-old lady, G1P0 lady. Got severe right iliac fossa pain. The last menstrual period was 8 weeks ago. She's got rebound tenderness in her right iliac fossa, and her urinary pregnancy test is positive. Are we worried or not worried? So some of you are thinking, what's G1P0? That means, so G1 means this is her first pregnancy. P0 means she's never had a baby before. She's never delivered a baby before. Gravida and parity, okay? So this is her first pregnancy ever. Okay, so a lot of you saying worried. Yeah, I would be worried too. Her obs are okay, but it's more the underlying diagnosis that I'm worried about. Her obs are actually pretty much okay, aren't they? Again, the quicker you answer, the more points you get. So which of the following is the commonest location for an ectopic pregnancy? That's what we are worried about in this patient. This is pretty tricky, actually. Ovary, or maybe it's not that tricky. I don't know, let's see. Ovary, ampulla, isthmus, fimbria, or cervix? So please do answer on the Menti. Please avoid answering in the chat if you would be so kind. Okay. I'm curious. Ooh. Oh, okay. I'm impressed, very impressed that most of you got it right. So ovary and cervix are super rare. Ampulla of the uterus does not exist. I made that up. So you're left with two options, of which most of you got it right. Okay, so let's go through the answers. As I said, exam technique, straight away, most of us probably know that an ectopic pregnancy happens in the fallopian tube most commonly. So we can exclude cervix, we can exclude ovary, and we can exclude the uterus question, the uterus answer, sorry. Ampulla of uterus does not exist. The ampulla of the fallopian tube is the commonest location overall. That was there to confuse you. Then you're left with isthmus of the fallopian tube and fimbria of the fallopian tube. So remember, exam technique can get you a long way. You've now narrowed it down to isthmus and fimbria. So this was, yeah, it was a bit difficult, but the isthmus occurs in 13% of cases, whereas the fimbria occurs in 11 to 12% of cases. But I think it's fair for you to know that the two most common locations of an ectopic pregnancy are the ampulla of the fallopian tube and the isthmus of the fallopian tube. So learn those as the two commonest locations of an ectopic pregnancy. Okay, so next question, I want you guys to take in the case again. So I'm not going to read it out for you, just have a half a minute reading through it and soak it in, because the next question is going to be based on this presentation. All right. So I hope you've soaked that case in. I mean, so the case is basically saying that we've got an ectopic pregnancy. The patient's observations are actually okay. She's in pain. TVOS, you might be thinking, what on earth is that? That's a transvaginal ultrasound. So that's how you diagnose an ectopic pregnancy. And it shows a pregnancy of 30 millimeters. Are you going to watch and wait, methotrexate, mifepristone, salpingostomy or salpingectomy? Tricky question, but something you need to know for your finals. So this comes down to knowing what are the indications for the management of an ectopic pregnancy. Okay, so you've got a pretty even split between methotrexate and salpingectomy. Interesting. Why surgery as opposed to medical management? What was the one thing in the history that said that we need to go straight for surgery here? So yeah, peritonic pain, basically. The patient was in severe pain. That's an immediate indication for surgery in ectopic pregnancy. So severe right iliac fossa pain. This is a classic presentation of ectopic pregnancy. It can mimic appendicitis in that it presents in the right iliac fossa. The pain is severe. She's got rebound tenderness, so she may well be peritonitic. So these are all worrying features. It doesn't matter that her observations are fine. You know, if we give this patient another hour or two, she may become seriously unwell and die. So there's no point of waiting for that to happen. You intervene straight away. You don't want to watch and wait because the patient will die, basically. They're going to rupture and bleed out. Methotrexate is the medical management of choice, but we need to take this patient for surgery urgently because the fact that she's peritonitic suggests that either she has just ruptured or she's imminently about to rupture. Mifepristone is not routinely used in ectopic pregnancy. That's more used in abortions. And then we're left between salpingostomy and salpingectomy. So when do you do a salpingectomy? When do you do a salpingectomy versus a salpingostomy? Salpingectomy is first line. That's where you actually take out the fallopian tube. You take out the tube with the ectopic pregnancy. If the patient's contralateral tube is okay, then that's not a problem because you can take out this one tube, but they still have their other tube, so they are still fertile. That's the first line surgical management. If the patient's contralateral tube is damaged for some reason, then you do a salpingostomy where you only remove the affected segment of the tube, okay? And you leave the rest of the tube in. Salpingectomy is first line. And some of you are asking, how would you know that there's a problem with the contralateral tube? So that's why I highlighted, this lady has never had a pregnancy before. She's otherwise well. You'd expect some history of tube damage, basically, but there was nothing about that in the history. So first line is salpingectomy. Ectopic pregnancy. So we had a good lecture on gynecological emergencies by a gynae registrar who knows far more about obs and gynae than I will ever know. But I know enough about the emergencies, so that's why I'm teaching this. Ectopic pregnancy is implantation outside of the uterus. 98% of cases are in the fallopian tube, the ampulla being the most common. So this is the ampulla here, the middle bit. The isthmus, I can never really pronounce that properly, but that's the proximal part of the fallopian tube. And then the fimbria. The fimbria is not actually labeled on this diagram, but it's basically the very tip of the fallopian tube. You know, fairly common, 11 in 1,000 pregnancies, and there's a risk of recurrence in the future. But this is the key slide here. Again, these slides will be released and you can go through this, but this is a summary on how to manage an ectopic pregnancy. If you go to our ectopic pregnancy webinar, this is explained in far more detail, going into each of the different options. But what I want to highlight here, the way you diagnose an ectopic pregnancy is on ultrasound. Once you've diagnosed an ectopic pregnancy, if they are in pain, you take them straight to theatre. So significant pain is an indication for theatre. Otherwise, you don't need to rush to theatre. You can have a think about what to do next. If they're clinically stable and there's no significant pain, you can think about what to do next. If the pregnancy is small, less than 35 millimeters, and the HCG is less than 5,000, you can manage them medically, or you can just wait and watch depending on what the HCG is. If the pregnancy is above 35 millimeters or the HCG is above 5,000, you take them straight to theatre again because there's a high risk of rupture. I think this is a pretty neat flow chart. So just learn this, and this is pretty much everything you need to know about ectopic pregnancy management in a nutshell. So go back and have a look at the slides. Okay, rapid fire round. We have 3 more questions. These aren't going to be case-based. These are purely standalone SBAs, and then we will finish up with a Q&A. So I can see someone's asked, what's expectant management? That's conservative management, where you just wait and watch. And it will resolve itself, hopefully. Which of the following is suggestive of a near-fatal asthma exacerbation in an adult? So near-fatal. So we have low saturations, and then a various PO2 and PCO2 readings, a peak flow of 30%, and a low blood pressure. Which of these would make you worried about near-fatal asthma exacerbation in an adult? So obviously near-fatal means they're about to die, so that's really bad. Good. I'm glad. It was a very close call between PO2, this option, and the peak flow. Okay, just to look at the answers. So all of the other options are suggestive of a life-threatening exacerbation, except this option here, because the PCO2 is raised. You need to know this cutoff. I didn't give you the cutoffs on purpose because this is something you should know for your exams. A PCO2 of above 6 is suggestive of a near-fatal exacerbation. If your PCO2 is raised, that is extremely worrying, and you need to get the patient to intensive care as soon as possible. All the other options are suggestive of a life-threatening exacerbation. So this is the chart that you need to know for your exams. Near-fatal is obviously the worst because it suggests they're going to die. Life-threatening is bad, severe is bad, moderate you can manage in the community in general. You can discharge patients with a moderate asthma exacerbation. The point is, there's only one thing really which differentiates a near-fatal asthma exacerbation from everything else, and that's the PCO2. So if the patient has a high PCO2, that means they have a near-fatal exacerbation, or if they need mechanical ventilation. So those things there, if they have either one of those, that's a near-fatal exacerbation. Peak flow of less than 33% is a life-threatening exacerbation. Low saturations, low PO2, but a normal PCO2, those are all features of a life-threatening exacerbation. Why are we so worried by a high PCO2? Because that means the patient is now getting exhausted to the point where they can't blow off carbon dioxide. They're becoming so tired from all the heavy breathing they've been doing, they can no longer blow off the carbon dioxide. Carbon dioxide starts to build up, and that can lead to toxicity, and eventually these patients will die if you don't treat them. Okay, next question. So the penultimate question, and then we will be done in about 5 minutes or so. I apologize for running over time. So this was from our ophthalmology emergency lecture, which was really comprehensive. So go do have a look at that. Which of the following is not a risk factor? For closed angle glaucoma, that's also the same as acute or narrow angle glaucoma. African ethnicity, various drugs, hypermetropia, or being female. Okay, tricky question, but something you definitely need to know for your exams. You definitely need to know the risk factors for closed angle glaucoma. So all of these are risk factors. Phenylephrine, atropine, hypermetropia, and female are risk factors. African ethnicity is not a risk factor. East Asian ethnicity is a risk factor, as well as the Inuit population, interestingly enough, also have a higher risk of closed angle glaucoma. Being African is not a risk factor for closed angle glaucoma. Any medication which causes pupil dilation will increase your risk of glaucoma. Phenylephrine causes pupil dilation, as does atropine. It's much more common, I think it's at least twice more common in females, and being long-sighted is also a risk factor. So these are the risk factors listed here. And what is closed angle glaucoma? So just in brief, you have the aqueous humor at the front of the eye in the anterior chamber. Normally that fluid goes into the trabecular meshwork, which occurs at this corner between the iris and the cornea, and that's known as the angle. And the aqueous humor drains out through that angle, which is marked by this black dot here. In closed angle glaucoma, this angle between the iris and the cornea becomes narrow or closed, and the fluid cannot escape the anterior chamber of the eye. The fluid builds up, the pressure builds up, and patients become, that's when patients become unwell and they develop closed angle glaucoma. In brief, so mydriatic drugs are drugs which dilate the pupil. The reason they increase your risk of glaucoma is by dilating the pupil, your iris gets pulled in towards the cornea, and that narrows the angle. So the iris gets pulled in towards the cornea, and that narrows this angle here. Examples of mydriatic drugs are atropine, sympathomimetics such as phenylephrine. This is the last question, and then we will reveal the leaderboard. Yes, so those are all good examples that people are listing. Okay, patients come in with abdominal pain and absolute constipation. That is their abdominal X-ray. CT confirms rectal cancer. What are you guys going to do next? Again, this is something you definitely need to know for your finals. If you find this question difficult, blame Azim because he actually made this question. Good, but a fair few of you got it right, so that's good. Defunctioning loop colostomy. Let's have a look at why that's the answer. So basically, the point is the patient has bowel obstruction as the X-ray showed. They have bowel obstruction. There were dilated bowel loops. So you need to do something about this. The reason the patient has bowel obstruction is due to rectal cancer. So the question is, how do we manage bowel obstruction secondary to rectal cancer? The answer is you always perform a defunctioning loop colostomy. That means you take a bit of the colon out and you essentially split it into two halves, and that's your loop colostomy. The key fact is here, you do not resect the colon. Okay, you never resect the colon for patients presenting with rectal cancer secondary to obstruction. Does anyone know why that might be the case? Why do we not perform a resection here? Okay, so the reason we do not perform a resection is because the risk, yes, someone's got it there. So the risk of anastomotic leak is very high in patients with rectal cancer. So if you take out a bit of the bowel and then join the two ends together, that's known as an anastomosis. In patients with rectal cancer, the risk of that anastomosis breaking down and leaking is very high. So we do not do that in patients who present with rectal cancer causing obstruction. Additionally, if you take out the cancer, there's also a risk that you're going to leave some of that cancer behind because you haven't properly staged the patient, you haven't done the appropriate biopsies. So with rectal cancer, you perform a defunctioning loop colostomy, you then go and do your proper staging with imaging, with biopsies, etc. And then you come back at a later stage and take the cancer out with a resection. You never perform the resection in the acute stage. Okay, let's go and have a look at the leaderboard. Actually, just before you head off, I'll briefly touch on this. So this is really important. Bite Medicine, we've been doing a lot of webinars and it's something we've really been enjoying, but some of you might not know that we also have an online textbook and a question bank, which is on our website. You can find it at www.bitemedicine.com. The question bank has well over 1,000 questions, and all of those questions are structured in the multi-step SBA format that we recommend. So you have a case history and then multiple questions based on that case history. And I think that's a far, far better way to learn than doing single SBAs where you have a question on one topic and then a question on another topic. Multi-step SBAs, the evidence shows they're much better for your learning. We have an online textbook with almost 300 topics on there at the moment, and we are doing our live webinars. Please do check that out and sign up. There is a bunch of free questions and a bunch of free online topics, textbook topics as well. So we'd really appreciate that. Just before you head off, this is what the question bank looks like. So it takes you through the case history, and you have questions right from first steps down to management and pathology. And again, our online textbook takes you through all of the key points that you need to know for the various things that will come up in your finals exams. But the thing that you all probably want to know is who won the quiz. So who was it that came? There was, I forgot the name of the person who was top halfway through. Dr. Evil, I like the name. Oh, Love Sight. They were in first place before, weren't they? I love Bite Med. Well, we couldn't have asked for a better winner, to be honest. Absolutely amazing work. Don't worry if you found this lecture hard. It's meant to be hard. It's top decile. Please tune in for our lecture tomorrow with Smile, where we're going to have a similar structure but cover different topics. So do tune in for that. I'm going to go through a bunch more questions. We're going to cover more topics. It's going to be a similar structure. Fill out our feedback form. The slides will be uploaded to our website, as will the recording of this entire lecture. So stay tuned for that. And I will stick around for 5 or 10 minutes for a Q&A. Azim will post the feedback. Feedback incoming. I will take your questions. You're all very welcome. Thank you guys for tuning in. It's an absolute pleasure to teach you all. You're all very welcome. My chat's a bit jammy, so it takes a bit of time for the questions to load. I will try and get some of them. What topics are on the quiz tomorrow? You have to tune in to find out. That is the cliffhanger, isn't it? Oh, you're very welcome. You're very welcome. Please do fill out the feedback. I'll stick around. You guys can fill that in the meantime. If you have any questions about any of the content or anything about medicine or whatever you want to ask, really, just post it in the chat. Okay, so where can we watch the recordings of lectures? They're on bitemedicine.com/watch. Shoaib is I'm very thirsty. I get dehydrated really quickly. Ruptured ectopic, do we still consider contralateral tube? Oh, hold on, these questions are coming in too fast. Contralateral tube, I don't think I quite understand. So basically the management in an ectopic pregnancy, if there's an indication for surgery, the first line is to take out the affected tube, the salpingectomy of the affected tube. If you have any concerns that the other tube isn't working properly, you don't want to go and take the patient's tube out, because then they won't be able to have kids. So instead of taking the affected tube out, you cut a little hole and remove the affected region. First line is salpingectomy, second line is salpingostomy if the contralateral tube is damaged in some way for some other reason. For example, they may have had pelvic inflammatory disease, which has damaged their contralateral tube. Therefore, you don't want to go and rip out their one functioning tube, because then they're never going to have babies. Will tomorrow's lecture be recorded as well? Yes. Can you give propranolol as prophylaxis against gastric variceal bleeds? So yes, you give it a secondary prophylaxis. So once you've sorted out the patient, you've given them terlipressin, you've given them their endoscopic treatment, the long-term treatment for variceal bleeds is prophylaxis with propranolol, because that reduces the portal pressures. Should we be taking vitamin D in lockdown? Probably, yeah. But, you know, I don't want to just have a good diet. You can take some vitamin supplements, not a bad idea. Can you explain the timing thing in the management of status epilepticus? Yeah, so early on, within the first 10 minutes, you give benzodiazepines and you can repeat the dose twice. After that, from about the 10th minute to the 60th minute, you can give phenytoin. If they do not respond to phenytoin, then you intubate the patient and take them to intensive care. Okay, is that everything? Can you tell the difference between obstructive and distributive shock? I can. So obstructive shock is something which blocks the heart from pumping. So something external to the heart itself, which is blocking the pump, which is blocking the pumping mechanism of the heart, such as a pulmonary embolus. So a pulmonary embolus is a clot. If you have a clot, the heart is going to have to pump against that clot, and that is therefore an obstruction, and therefore known as obstructive shock. So anything which obstructs the pumping of the heart is known as obstructive shock. Distributive shock is anything which causes high, vasodilation. So anaphylaxis or sepsis, they cause vasodilation. You then drop your blood pressure, and that is an example of distributive shock. Okay, final couple of questions. There's a few questions on this benzos. So why give 2 benzos? Because if you give 2 benzos, you're gonna have more benzodiazepines in the bloodstream, and therefore the higher dose is more likely to be effective. And benzodiazepines act quickly. They're very good at terminating seizures. Okay. I think we'll wrap it up there. There's a lot of good questions coming in. You know what, hold these questions till tomorrow. I don't want to keep you guys so long, because I'm sorry that we've overran by 20 minutes. But you are all very welcome. It's been an absolute pleasure as always. Take care, fill out the feedback form, join us tomorrow, and stay safe.